Hello, students. This starts chapter 8, so you should be in week 2, community pharmacy practice, healthcare and prescription drug insurance program. So this audio slash video lecture basically will go over one of the important aspects of retail pharmacy, and that's basically um, insurance and healthcare coverage. So these are some of the topics I will cover in this video. I'm just going to name a few. Rising costs of healthcare, health insurance components, commercial health insurance, resolving claim issues. So this is actually going to be a two-part lecture because it's pretty in-depth. Again, this is in chapter 8 in your book, which basically goes over the insurance process. So here will be your learning objectives. Um, Understand the importance of insurance to address rising prescription drug costs. You can look over these three, define key terms such as average wholesale price, monthly premium insurance. So after this lecture, you should have a good idea of how the insurance process works, the key terminology. All this should be pretty much familiar with you, different insurance plans, Medicaid, Medicare, private insurance. And you can just read through the learning objectives. I won't go through each and every one of them, but the objectives just basically explain what the chapter will actually cover. So here's the actual introduction. This is slide 5. Almost 90% of Americans have some type of private or government insurance for hospital, medical, and prescription drug benefits, or a combination of healthcare coverage plans. So as you can see, a good population have insurance coverage. Every insurance company has its own unique eligibility and payout criteria based on deductibles and co-payments. So what this basically means is one person could have Aetna insurance, another person could have Blue Cross Blue Shield. They could go to the same pharmacy and have the same prescription, but have totally different co-pays. Also, you could have different payout criteria, even if you have the same company. So if you have Aetna insurance at your job, it just all depends on what selections you choose when you enroll each year, because there's different selections that can either bring up the price of your insurance or it can lower it. There's different deductible packages that you could actually opt for. So normally most people have, even if they work for the same company or they have the same insurance plan, their copays could be different. The only the exception to that rule is with Medicaid, because Medicaid is pretty much the same across the board. But with private insurance, it varies. You will need a working knowledge of all these various health insurance programs in retail or mail order pharmacy. That's because you'll be billing insurance companies. You will spend 20 to 25%, so that's basically 1/4 of your time entering, updating, and processing insurance-related information, as well as resolving issues and educating patients. The one area where you would need to educate patients is a lot of people think because they have insurance that all medications must be covered because they have health insurance, and that's not the case. You could have health insurance. The doctor could write you a prescription for a medication that's not covered under your insurance plan. Every insurance plan has a unique set of medications that they cover, which we'll talk about a little bit later. Just the same as medical insurance. People think if they have medical insurance, it will cover every single operation. Obviously, you should know that's not the case. There are some operations that insurance companies will not cover. Most obvious ones are cosmetic operations. If you're getting a nose job or any type of physical enhancement, most insurance companies will not cover that type of operation because it's not what they call a medical necessity, meaning people who get, for example, if they get a nose job, surgery to change their nose for whatever reason, or change any body part, Most insurance companies see that as a what they call a cosmetic option, meaning you want to physically look better. You're doing that surgery so you can physically look better and feel good about yourself. It's not as if you don't get if you don't get this operation, your health will be in danger. So normally insurance companies will only cover what they call medical necessities, operations that affect your health. And then in some cases, the insurance companies may feel even if it's a medical operation, it's not cosmetic, they may think it's not necessary and they want more evidence from the doctor to prove that the person needs this medical surgery and cannot do other options. So it's going to vary. Insurance coverage can mean the difference between access or no access to life-saving drug therapies. And you guys should know about that right now because literally as I'm speaking, the Supreme Court is actually looking at getting rid of the Affordable Care Act, where it actually covers pre-existing conditions. That's literally as I am lecturing right now. That's at the Supreme Court right now. So it's a hot topic in politics as well. Knowing how to process insurance claims can make a real difference in people's lives. And to be honest with you, when you get in retail, processing insurance is fairly easy once you get familiar with it. It's nothing really difficult. Rising costs of healthcare. So this is a huge problem, and I mean huge problem in the United States. The cost of healthcare, especially prescription drugs, is far outpacing the rate of inflation. So normally what you want in a society, you want the rise of any product to stay close with inflation. That way you have a pretty much a balanced economy and you don't get a situation where people can't afford food, gas, or whatever. Usually things go up with inflation. They kind of stay level. You want to keep it level. Um, if you did, for example, back in the, let's say the 1940s, a gallon of gas was probably 50 cent, or a loaf of bread was probably a nickel back in those days. Um, Obviously, that was nearly 80 years ago. Um, Prices go up, but they have to stabilize because one thing I hear a lot is people look at what things used to cost way back in the days. Like, for example, literally when I said a probably in the 1940s, loaf of bread was probably a nickel. So a lot of people say, oh, things were so cheap back in those days. Not necessarily because a nickel back then went way further than it goes now because you got inflation. It wasn't like people had the money that we have right now in 2020 back in 1940. So 1940, believe it or not a lot of people didn't have a nickel wasn't as widespread as it is nowadays. In 1940, it would be tough for a person to give you a nickel just to, get you out of their face or whatever. Whereas in 2020, if somebody gave you a nickel, you will probably laugh at that. You'll probably say, "Oh, what can I do with this?" And that's because of inflation. Um, Over years, things go up, but when you have inflation, you want the price of food and all other commodities to basically go up with the same rate as inflation. When that happens, the economy sort of stays stable. Okay, but with prescription medication, the prices of the medication has far outpaced inflation. Meaning, in 2020, the average person, if you were paying cash price, probably couldn't afford prescription medication if they didn't have insurance. That's because the price of the drugs have outpaced inflation severely. So costs continue to rise, an increase in innovative and expensive new drugs. So new drugs are hitting the market every single day. Every year, a lot of new drugs and a lot of really good new drugs come to the market. But the problem is drug manufacturers, when they create these new drugs, it's real expensive to them. So when the drug gets approved by the FDA, the drugs are very expensive and the drug manufacturers tried to get their profit back. So the drugs come to the market already with a very high price. Manufacturers boosting the average wholesale price of brand name and generic drugs. Again, drug manufacturers, they're in a business to make money, to make profit. So they typically raise the price of their medication when it comes to the market. Sadly, at one time, generic drugs were basically dirt cheap. And the reason why they were dirt cheap is because they didn't have to go through all the testing that the brand drug has. So basically, they're just making a knockoff of the brand name. But generic companies have become very greedy, and they have actually raised the price of their drugs when there's no need to raise the price of a generic drug. Because you're basically just doing a knockoff. You're just basically duplicating the brand drug. It's not much money into making a generic drug. You just need the raw material. Whereas the companies who make the actual drug, the brand name drugs, they have to put in a lot of money for research, and they have to pay for all that, and they have to send this off to the FDA. So they're obviously spending a lot of money creating and researching the medication. The generic companies are not, but for some reason, they have become very greedy, and they're raising the price of the generic drugs. So AWP, again, is the average price that pharmacies, hospitals, and other healthcare facilities pay for stock of a specific drug. Average whole price is, or AWP, is used in every business. To give you an example of how average wholesale price works, take, for example, a loaf of bread that you may get at the supermarket. Let's say Kroger's supermarket. Okay, Kroger's, they don't get that bread shipped to them for free. They got to pay a warehouse. They got to pay for that bread. So what they do is basically the way it works. Kroger's, in order to get bread into their supermarkets, they have to order it from a warehouse. And the warehouse that they order it from sells it at a certain price. So they sell it to Kroger's at a certain price. The price they sell it to Kroger's is much cheaper than the price that the customer pay. So Kroger's, for example, may purchase the bread for $1 a loaf. So they purchase the bread from the warehouse at the AWP price. So the warehouse sells it to the business for, let's say, $1. Once that bread gets shipped to Kroger's, before it gets put on the shelf, Kroger's has to make a profit. So they're not going to sell the customer the loaf of bread for $1 because they'll be breaking even. So they paid $1 for it. They're not going to put it on the shelf for 50 cents because they're losing money. They spent $1 to get the bread. They're not going to put it on the shelf and sell it to the customer for 50 cents because that would not be smart. They would be losing money. So they have to make a profit. So Kroger's will actually increase the price of the loaf of bread to maybe $1.50, $1.75. So when the customer purchases that bread, Kroger's makes a profit off of it, and that's how they stay in business. You go into business to make a profit. You don't go into business to stay even or break even or lose money. So that's all the AWP is. It works the same way in the pharmacy. When the pharmacy purchases medications from a warehouse, they purchase it at a much lower price. And then when they get the product into the pharmacy, they sell it to the customer at an increased price so they can make a profit. So another reason why drug prices are going up, fewer brand drug names are coming off patent. A patent means you have exclusive right to market that medication before a company can make a generic. Usually the average years for a patent is roughly now about 10 years. There are some exceptions to the rule. So here are some rising costs of healthcare. Most of the current research and development, also sometimes abbreviated as R&D, pharmaceutical costs are going into creating new and more expensive innovative drugs. So the drug manufacturers are actually investing a lot of money in creating new drugs. So that's where most of the high cost is coming from. because it costs a lot of money to pay those researchers and scientists. And then you got to pay the people that you're testing the medication on. The high AWPs of specialty drugs now account for about 33% of all drug spending, and this is projected to reach 50% in the near future. Specialty drugs are basically a new class of medications. They're very expensive medication. They usually treat conditions like rheumatoid arthritis, a lot of cancer drugs, hepatitis, but they're extremely expensive to make because it's a lot of, sometimes you hear it called biologics. It's a lot of technology that goes into making these drugs. They're not very easy to make. It's very expensive to make these drugs, so they call specialty drugs. And most of these drugs are not even kept at your regular CVS or Walgreens. They're usually kept at a special pharmacy called specialty pharmacies because of the price of the medications. They're very expensive. Some of these medications that you see on this chart, like Levic, the cash price for a 30-day supply, if you didn't have insurance, could be anywhere from $25,000 to $30,000. So a lot of these drugs are multi-$1,000 medications, very expensive, that if you didn't have insurance, you would have to be extremely wealthy to afford these. And I mean extremely wealthy. Even somebody who makes $150,000 a year or $200,000 a year, that's a very high income. They could not afford paying cash for a medication that costs $25,000 a month. They couldn't do that. That's just out of their price range. So you can see how expensive these medications are. So how are prescriptions processed and paid for in the pharmacy? So prescriptions are processed and paid for basically in a few ways. There's still some people who pay cash. They don't have any insurance at all. They get a prescription from the doctor, take it to the pharmacy. They ask the technician what's the cash price for the medication. Technician gives them an answer, and they either pay it or they don't pay it, depending on if they could afford it. So some people still pay for prescriptions cash, and that's normally because they don't have insurance. So that makes up 7.8% of the population. Still, the majority of people still have third-party insurance. And this is private insurance or insurance through the employer. So this is insurance like Aetna, Blue Cross Blue Shield, Cigna, Caremark. Those are private insurance that you normally get through your employer. So that makes up the majority of how actually prescriptions are processed and paid for with third-party insurance. Then we have the two government insurance. We have Medicaid and Medicare. That makes up the remaining balance, which is roughly for Medicare is 25.7%. Medicaid is 13.3%. So still, private insurance is still the most popular way, followed by Medicare, Medicaid, and then cash. And I want to distinguish between Medicaid and Medicare. So Medicaid is state funded. So there's 50 states. Each state has their own Medicaid program and standards. And Medicaid is typically based on your income. Okay, usually to qualify for Medicaid, you have to be in a certain income bracket. Medicare is federally funded, and everybody qualifies for Medicare once they turn 65. You automatically get Medicare Part A, which you can use at hospitals. So Medicare, for the most part, think of it as based on age. There are a few exceptions to the rule because if you have a disability, even if you're just say 25 and you have a lifelong disability that you will never recover from, that you have to live with for the rest of your life, you could qualify for Medicare under those circumstances. So you could be 25 technically and have Medicare if you have some disability that will be with you for the rest of your life. You can qualify for Medicare. You also could have both Medicare and Medicaid. And we'll talk about this a little later because there are a lot of people who have both Medicare and Medicaid. When you have Medicare and Medicaid, Medicaid is always billed last because you can bill both of them at the same time, but normally Medicare will pick up the majority of the payment, and Medicaid will pick up what Medicare does not pick up, if that makes sense. Or if the drug isn't covered by Medicare, Medicaid will kick in. You will never bill Medicaid first. Medicaid never pays first when you have Medicaid and Medicare at the same time. And really don't worry about this because in the real world setting, um, Medicare and Medicaid actually work together. So Medicare will know if their client has Medicaid, and Medicaid will know if their client or the patient has Medicare. They sort of work together. Um, so basically, what that is saying is, if you try to bill Medicaid and the person has Medicare, it will reject because Medicaid will know that the person has Medicare. Vice versa, Medicare will know if you have Medicaid as well. So that's why I say you really can't mess it up in the pharmacy business because those two government insurance, they sort of share their information where the one knows what the other has and vice versa. You also have something called workers' compensation, which is really not private insurance or government insurance. Basically, what workers' compensation is, there are federal laws that basically state if you work for a company and the company does something, I'll just say the company has some kind of defect. You're sitting at your work table, minding your business, and uh, some panels from the ceiling fall down and hit you in the head, and gives you a concussion or whatever. So you're going to need some pain medication, and you may need to go to the ER to get some stitches or whatever. If you get injured at your place of employment and it's not due to any fault of you, there are laws where the company has to pay for your medication, or it has to pay for if you have to go to the doctor's office, it has to pay for your medical expenses. That goes under workers' compensation, um, where basically the company is actually paying for your medication and paying for your medical injury if there's any kind of injury. So it's called workers' compensation. And I'll get to the discount plan and manufacturer coupons in a little bit. So cash prescription. So this is the most profitable for pharmacies. So cash mula dinero. This is the easiest to process because it is most lucrative for pharmacies because they're not sharing any of the money with the insurance company. You're basically paying retail price when you pay cash for medication. So this is where the pharmacies make the most profit if when customers pay cash and have no insurance or third party. Whenever a person pays cash, there's never a rejection, and all claims will go through with no problem. The obvious disadvantage to the consumer is that they are paying full retail price for the medication, assuming that it's not a part of Walmart's $4 plan or any other competitor's plan. Cash prescriptions, from a pharmacy perspective, you have to be a lot more careful when processing prescriptions that are filled on cash because it's much harder to catch therapy duplications and or abuse of medications, especially abusive medications. When people have controlled substance and they pay cash, um, it was a little bit harder to catch people abusing medications because if they had insurance and they tried to fill something at Walgreens and then tried to fill something else at CVS, the same medication, well, even though Walgreens and CVS have different computer systems, they all are billing the same insurance company. So Walgreens will know if you had a prescription filled at CVS and vice versa. CVS will know if you had that same medication filled at Walgreens a couple of days earlier because they're all billing the same insurance company. But when a person pays cash, uh, there's no company that they're billing. You just basically paying cash, so it's a little bit harder to track. The majority of customers who abuse controlled medications normally are people who pay cash for prescription because it's harder to track and very easy to doctor shop when you have no insurance. So the term doctor shopping means obtaining controlled substances from multiple healthcare practitioners without the prescriber's knowledge of other prescriptions. So this is like you want some pain medication and you get so desperate that you go to, and one day you go to 4 different doctor's offices. So you start off in Plano, you go to a doctor's office and say your back is killing you and you need some pain medication. The doctor usually in Plano is going to ask you, are you seeing any other um, doctor, are you under the care of any other doctor? So the person doctor shopping will say no. And then the doctor will write them a pain medication. Then they go to Frisco and they do the same thing, and they go to Mesquite, and they go to anywhere, Oak Cliff or whatever, or another part of Dallas, and they just go to multiple different doctors' offices and they paying cash. The one good thing about it is that recently they came up with this new system. So this is further information on doctor shopping. They have this new system now where this is almost impossible to do right now. They have this computer system that when you go to a doctor's office, whether you're paying cash or you have insurance, the doctor enters the information into a database that they've seen you on this particular day and they've given you this particular medication. Well, now pharmacies also have that same database. So when a patient is paying cash, the technician can open up that database, enter your information, and they can tell exactly what doctor you've been to, if you've been to prior doctors trying to get the same medication. So doctor shopping is almost impossible to do right now, but I just wanted to let you know it did exist. Many of you probably seen these around. This is discount plans. So these are prescription discount plans are designed to provide lower drug costs to patients paying for their medication in cash. Keep in mind, discount plans are not insurance. They're basically, as they sound, discount plans. No different from when you have coupons in the Sunday paper that takes 50 cents or $1 off this particular product, and you give the little coupon to the cashier when you're scanning out your products. Same thing. But there's a couple things to know. Cash discount programs are not healthcare insurance, and additionally, Medicare and Medicaid do not consider discount plan as coverage, so they do not have financial responsibility for prescription plans. Cash discount plans are coded in most pharmacies to prevent coordination of benefit. Coordination of benefit is basically when you have 2 insurance companies and you're billing them at the same time to lower your price, but you cannot have Aetna insurance and use a discount plan at the same time, or have Medicaid or Medicaid and use it with a discount card, because they're coded differently and they won't allow you to use a discount plan with a insurance company, whether it's Medicaid, Medicare, or whether it's private. GoodRx is probably the most popular one. You enter the discount plan the same way you enter insurance. It's the same process. They have BIN, PCN number, group number. Basically, discount plans are really designed for people who have no insurance. So it just lowers their price. They're normally paying cash, and they want a discount, but they want to use a discount plan. It'll knock some money off the original price. Next time you go to the doctor's office, they usually have a lot of these right at the receptionist desk that you can take one and take home. They're usually all over. That's the way they work. Manufacturer coupons. This is a little different. Manufacturer coupons are basically, obviously, they're coupons that come from the manufacturer, and they can be used in conjunction with third-party insurance, but not with Medicaid or Medicare. So you can use one of these if you have a private insurance like Blue Cross Blue Shield, Cigna, Aetna, United Health, or whatever. Basically what it is manufacturer coupons are built in the same manner as third-party insurance. Are basically designed to help patients afford what would normally be a very expensive copay. So most of these are brand name medications. And say, for example, you could have insurance and the doctor could write you for a brand name medication that doesn't have a generic. You take it to the pharmacy, they bill it with your insurance, and you could get $100 copay back. $100 copay is still pretty expensive to most people. Most people don't want to pay that every month. They rather pay something like $5 or $10 or maybe $20 copay. Well, sometimes what can happen is the manufacturer could have a specific coupon for that drug that will lower your copay. So the patient presents this coupon, and just say normally this would have been $100 on their private insurance. They present this coupon. The technician bills the third-party insurance and the manufacturer coupon at the same time. And as you can see on this card, this Eliquis, it will bring the price down to a $10 copay, which the person will find pretty affordable. So it's like a win-win situation for the manufacturer. So the manufacturer eats up most of the copay, but they don't care because the pharmacy has to order that medication, and that medication is being dispensed. On this other one here, the Vyvanse, this one basically says you will pay no more than $30 per prescription. So their copay could be anywhere between, let's say $10 and $30. If they didn't have this coupon, it might have been, $100 or more. So that's the purpose of manufactured coupons, just to lower the copay. And some of them, there are some manufacturers that will actually offer a coupon where you pay actually zero. It just varies. So health insurance components. So I do want you to be familiar with this. Health insurance helps patients cover incurred medical costs for such items as pharmaceuticals, such as prescription meds, physician visits, this is going to the doctor. Sometimes you have to do special lab like blood work that you got to pay for, and hospitalization. That's if you're actually staying at the hospital. Your insurance has to pay for that. Healthcare coverage in the United States may be provided by commercial insurance. So this is private insurance. Commercial, third party, sometimes you see those words interchange. So commercial insurance paid by the individual or through the employers with shared premium costs or by one of the state or federal programs. So I want you to be familiar with the different plans, and I think I break them down a little bit later. You got Medicare, and you got 4 parts, A, B, C, and D. And again, these are for people, you have to be at least 65, so you got to be over 64. Or if you're disabled, regardless of your age, you can qualify for Medicare. And I'll break this down a little bit later, the different sections, A, B, C, and D. Medicaid, when you think of Medicaid, you should think of low-income patients, okay? And again, these are individualized by the states. So each state has their own unique Medicaid program. A little FYI, Medicaid is state specific, where Medicare is federal. Medicare is all over the United States. For example, if you have Texas Medicaid and you take a trip to Oklahoma or Florida, and you're going to be there for a month, well, you cannot use Texas Medicaid in Oklahoma or Florida. Actually, you can't use it in any of the other 49 states. Same thing, vice versa. You cannot use Oklahoma Medicaid in Texas. You cannot use Florida Medicaid in New York, or New York Medicaid in California. Medicaid is state specific. Now, there are special scenarios, but they just for a limited time. For example, in, I believe it was 2002, in Louisiana, when they had Hurricane Katrina, that was a very bad hurricane. A lot of people got displaced because their homes were destroyed, and the residents of Louisiana traveled to Texas. Texas was like Texas and I believe Georgia were the two biggest states that most of the people who were affected by Hurricane Katrina traveled to. So when they traveled to Texas, they had their Louisiana Medicaid. Okay. But the state of Texas made an exception that until the crisis was over, they allowed uh, people with Louisiana Medicaid to use it in Texas, since a lot of them moved to Texas. Um, so in situations like that, where you have natural disasters, the state will do a temporary override where they'll allow that particular state, since they're going through a disaster, to use their Medicaid in in their own state. So that happens every once in a while, but normally the Medicaid is state specific. You have something called CHIPS, which is a part of Medicaid, but is designed for children, though. So child health care insurance programs and the Affordable Care Health Exchange, these are administered on the state level, and they're part of the Medicaid program. Um, you also have what they call TRICARE. Anytime you see the word TRICARE, it's military insurance. It's for active military veterans and military dependents. So it's for people who are active in the military, or they're veterans, and or they have dependents. If they have kids, the kids will be under TRICARE. That's just basically a military insurance. Health insurance components. So commonly, patients have one primary health insurance plan, which pays up to its coverage limits. Some patients may also have secondary health insurance plan, which pays what the primary does not. This is like having Medicaid and Medicare. Remember, Medicaid will always be the secondary. The patients may still have out-of-pocket costs even with the two insurance plans. So this is basically saying you could have two insurance plans, but you still could have a $5 or $10 copay, or any monetary amount of copay. So here's a couple definitions. Just try to be familiar with them. First party, you may hear this term. The first party responsible for covering a medical bill is the patient, parent, or guardian. Second party is the healthcare provider. And this is the more common one, the third party. This almost always means the insurance company. Okay. And here are some common third party carriers that you can just familiarize yourself with: Aetna, Blue Cross Blue Shield, Caremark, Cigna, Humana, United Healthcare. Here are some key health insurance definitions that I want you to be familiar with. To receive health insurance coverage, the patient pays a monthly premium or enrollment fee. Your premiums are usually deducted out of your paycheck. You should be able to look at your paycheck stub and see a portion of where your premiums are going, because you got to pay for your healthcare insurance, and usually they deduct it out of your paycheck. So you should definitely see that on your pay stub. So you have to pay a premium or enrollment fee. Normally, this is going to vary. You have something called a deductible. Okay. A deductible is the designated amount of annual medical costs that must be paid by the patient. Here's the key word: before the full coverage by the insurance company kicks in. And you could have deductibles that could $500, $5,000, $10,000. You actually have to pick your deductible. Usually, if you have maybe a lot of dependents, and you go to the doctor a lot, meaning you have a lot of medications, and maybe you're going to have a lot of operations, it would be pretty wise to get a high deductible. Higher deductibles are better for people who know they're going to have a lot of operations, or if they own a lot of medications. You wouldn't want a high deductible if you know for sure you're not going to have any kind of operations this year, and maybe you only take one medication, that would be pretty pointless of getting a high deductible. In that case, you will want a low deductible because you're not going to use that service as much. So these are just an example of, for example, plan designates a 5,000 deductible for an individual. The patient must pay for a large portion of or all of the medical costs up to $5,000 before the insurance company kicks in. So maybe you pay that $5,000 in 3 or 4 months, and the remainder 8 months, the insurance company will pay for your remaining operations. Your medication will be at a very affordable or cheap price. Um, and this is true. The higher the deductible, the lower the monthly premium. So normally, if you're paying high deductibles, normally you get a low premium. They kind of go hand in hand. Patient copayment. So you got a copay. This is the portion that the customer is responsible after the insurance has paid their portion of it. So this is what the patient always pays, the copay. So you may have a prescription copay of $10, $20, $50. When you go to the doctor's office, um, normally you have a copay that you're paying at the front desk, and it can vary. It just depends on how your insurance is set up. But by definition, copay basically means the portion that the patient has to pay. Patient copayments, again, healthcare plans have a tiered copayment system. The word tiered means threes, such as $20 per non-emergency office visits and $200 per emergency room visits. That is why it is not, unless it's absolutely necessary, you want to try to avoid using an emergency room as your doctor, because your copays, even if you have insurance, your copays are going to be much higher. The way insurance companies are set up, they rather you go to your primary doctor before you go to the emergency room, unless it's just something that you can't actually avoid. If you got a seriously bad burn, um, just say you poured some hot oil on you and it's burned through your skin. Uh, you want to go to the emergency room. You don't want to say, I'll go to my doctor's office tomorrow if you got a burn on your skin that just happened. So some circumstances you have to go to the emergency room. But if you wanted to basically wanted to find out if your blood sugar was high, that's something you don't want to go to the emergency room for. Hence the word emergency. You can, if it can hold on to when you can make an appointment with your doctor. Or for example, if you have acne issues, going to the emergency room to treat acne is not ideal. It'll basically cost you money. That's something you can schedule with your doctor, set an appointment. Um, and also they have, you have emergency rooms, and then you have the urgent care. Urgent care's copay is a little bit more than your doctor's office, but they less than emergency rooms. So the way most insurance are set up, they rather you go to your doctor's office first, if possible. If that's not possible, they rather you go to an urgent care place like Care Now or the Minute Clinics. Um, Urgent emergency rooms are the last option that they want you to go to unless it's absolutely necessary. Normally, emergency rooms are basically set up for people uh, for emergencies. You broke your leg, somebody got shot, somebody got stabbed. They really want the emergency rooms used for those type of incidents, not, oh, I have acne, let me go to the emergency room and see if they get, you know, some treatment for that. Um, so again, just look over this slide, patient co-payments and different formulary tiers. If you have Medicare, you have something called catastrophic insurance. This is an insurance that it's optional that you can opt into. And it's aimed at assisting a person who has experienced a severe accident or unexpected debilitating illness or disease. Um, this just basically adds extra coverage, especially for Medicare, because Medicare, you can actually run out of Medicare. And roughly around this time of the year, usually October, November, people reach their Medicare limit and they go into what is called a donut hole. And once they reach the donut hole, their copays go up unless they have catastrophic insurance, what actually kicks in. Um, but you have to actually enroll in this. It's not guaranteed. So, what are some pharmacy benefit managers, also known as PBMs? I want you to be familiar with this. Both Misty and I work for a PBM. We work for Caremark, which is a primary benefit management company. So these PBMs, there are other PBMs as well. Blue Cross Blue Shield has a PBM. Um, I think there's about three of them. CVS Caremark is one of the biggest, if not the biggest. So nearly all insurance companies and plans that handle prescriptions work with a pharmacy benefit management or manager, also known as PBMs, a division of the insurance company or a separate company that processes patients' prescription claims. So what we do at a PBM is we process different insurance claims. We have care at the one Misty and I work at. We contract with Caremark, Aetna. Um, we have a couple of Medicaid accounts and a couple of Medicare accounts. So we just process their insurance claims. Because of the increasing size and complexity of pharmacy benefits, many plan sponsors contract with PBMs to administer the process for them. So we're basically doing the job of the insurance company, to make a long story short. And this is a little bit more of what PBMs actually do. They are third-party administrators of prescription drug benefits. This is some of the tasks that we do, collecting funds from healthcare sponsors or health plan sponsors and use those funds to pay providers. So we pay providers, we process claims, answering questions posed by pharmacists, doctors, and healthcare participants. The other thing we do is negotiate with drug companies to try to bring the prices down. Drug companies normally their medications are very high. The insurance companies don't want to pay that price because they just believe the drug company's price is too high. The PBMs come in and negotiate with the drug companies and the insurance companies where they meet at a particular deal. So a drug manufacturer may bring a drug to the market and say, well, our drug is going to cost $10,000 a month. The insurance companies don't want to pay that kind of money because they're in the business to make a profit as well. So they may say, no, we're not paying $10,000 a month for this medication. This is where the PBM comes in. So they act as what they call middlemen. So they kind of negotiate with the drug manufacturer and say, hey, what's the lowest you can go? Um, where can you meet the insurance company? What kind of deal can we have? Then the drug manufacturer may say, well, all right, our original price was 10,000. We'll do 3,000 and nothing lower. Then the PBMs go back to the insurance company and say, hey, 3,000 is the lowest they go. What do you think about that? And the insurance company may accept it or whatever. Sometimes the PBMs will basically set the price. The insurance companies, the drug manufacturers may try to sell their medication at $10,000. And then the PBMs may say, oh, no, that's too much. We're knocking off 5,000. You can bring it to the market at 5,000. So sometimes they set the price. The impact of PBMs have become a lightning rod for controversy. A lot of people don't like them because of business practices described below. PBMs represent themselves as prudent managers of drug benefits, prescription drug benefit costs to health plans are doubling every 5 years. And the PBMs have been making a large profit. So a lot of people look at them as being pretty greedy because they hold the upper hand. Um, they're really the more powerful one between the insurance companies and the drug manufacturers and the pharmacies. But they're supposed to be neutral and be fair to all three of them. Insurance billing codes, just be somewhat familiar with these. Really just one that comes up a lot. Um, the one that comes up a lot, and sometimes you may see this on prescriptions, especially if you work for mail order, is the ICD-10 codes. ICD stands for International Classification of Disease. They update these codes usually every 3 to 4 years, and it's a way of actually billing, especially all doctors' offices use ICD-10 codes. So for every disease, there's a code. So if somebody has diabetes, um, there's a code for it. Like I know the code for that because I work in PBM. It's E19. You don't have to memorize the codes. If a doctor has a patient with depression, I know the code for that since I see it so much is F33. Hypertension or high blood pressure is I10. You need these to actually in doctor's office when you're billing insurance companies because it lets the insurance company know what type of condition the patient has. So they're international classification of diseases. Just know that they exist. Obviously, I don't need you to memorize different types of coding. There's something else, and this is just FYI, called HCPCS, Healthcare Common Procedure Coding Systems. Mainly, you see these used in doctor's office when they're billing insurance codes for Medicare equipment, Medicare supplies like wheelchairs, walking canes, things of that nature. Um, CPT, again, is used in doctor's office a lot to bill insurance companies current procedural terminology. This records procedures and services that the doctor's office may perform. So a little FYI there. Closer look at insurance billing codes. So insurance codes usually want a diagnosis because the diagnosis basically make sure the doctor's actually prescribing the right medication for that medication. Um, so you got to have a diagnosis. Your diagnosis just depends on what you're going to the doctor's office for. Are you seeing a psychiatrist for depression? Um, and if the doctor finds out that you have depression, they give that diagnosis. So a diagnosis is a label that identifies a patient's conditions and complexities because the drugs they prescribe should match the diagnosis. Okay. Um, a doctor should not be prescribing an acne medication and you don't have acne. It would be no sense of actually doing that, or prescribing a depression medication when you don't have depression. So it basically categorizes patients, defines the care that should be provided to patients, identifies the main reasons providers are caring for individuals. So a diagnosis code actually identifies a lot. Medical diagnosis, referred to as a primary diagnosis, defined by the physician or provider, usually defined to define disease, disorder, or condition. And again, here's the ICD-10 again, just so you're familiar with it. This is the latest one. Again, they change every 3 or 4 years. You can kind of look at this as FYI. Really won't test you deep into it. The codes are 3 to 7 characters. First character is always alpha, meaning it's always a letter. Second character is always a number. 3 to 7 can be either or. So in the ICD-10 code, the first digit is always a letter. The second one is always a number. Third one can be either number or letter, but it's usually a number. So just look at that as FYI. And here's how they actually structured. First digit, again, is always a letter. Second is always a number. So you can actually just look at these as FYI for the ICD-10 codes. So we use these codes, just skip through these. Here's something else that's become popular over the years. Health saving codes. or health saving plans, I should say. So a lot of employees offer this as well. So you have a health savings account, and they issue a little card that looks like a credit card, but it can only be used in healthcare at healthcare institutions or products that are somewhat related to healthcare. Because in some healthcare savings account, you could use it to purchase over-the-counter aspirin or Tylenol or Band-Aids. But if you try to use that card to purchase milk, it won't work. It just covers uh, certain over-the-counter medications or devices. So to assist people in putting money away for healthcare costs not covered in high deductible insurance plan, there are health savings plans or health savings accounts known as HSAs. Savings account can be started by patients or their employers to set aside tax deferred money specifically for healthcare costs not covered by the insurance. So it's a way of having extra money on the side. Um, so when you get paid, there's a certain amount of money that goes from each paycheck into this health savings account. The money is deposited before taxes. It can be used only for legitimate health bills. For 2020, if you have a high deductible health insurance plan, it can contribute up to 3,550 for self-only coverage and up to 7,100 for family coverage. So these are the max that you can actually have on these cards. The unused deposits in the HSA may accumulate from 1 year to the next. So these actually roll over, meaning if I have actually a health savings account, so if I had $3,000 on December 31st, um, on January 1st, I'll wake up with that same $3,000 in my account. So it goes from, it rolls over from year to year. Whatever you have remaining in 2020 will be there in 2021. Now you have something that's similar, but it's a little bit uh, different. Um, you have flexible spending accounts. So in flexible spending accounts, patients through their employer can also place pre-tax dollars aside for medical expenses and child and dependent care. Um, the main difference with this one is you have to be a little bit careful because you got both of these look alike. So one is the health savings account, it's the flexible spending account. So HSA versus FSA, flexible spending account. Both of them will give you little credit cards that look like regular credit cards. Again, they can only be used at medical facilities. So if you try using this to get gas or food, it will not work. The difference with the flexible spending account is it's more so use it or lose it. Um, and again, these dollars must be carefully predicted and spent within the year. And again, there are some companies that allow you to um, basically carry $500 over from a flexible spending account, but most don't. Sometimes if you listen to the radio, you may hear little commercials, especially with I hear it a lot with dentist offices. They will say something like, the end of the year is approaching, and if you got a flexible spending account and you got $1,000 left, come see us because once the new year starts, that $1,000 is gone. And that is true with a lot of the flexible spending accounts. You have to basically use that money up before the new year starts or for your new health plan starts because it typically doesn't carry over. So normally if you have a flexible spending account and let's just say your plan starts over January 1st, if you got $1,000 left in your flexible spending account, you're going to have to use it up before the year is over. And ways some people use it up is usually they'll get some dental work. They'll get their teeth cleaned, teeth whitened. But sometimes it becomes a real pain if you have a lot of money left and it's approaching the end of your end of the year, or your plan is about to start over, because nobody wants to leave $1,000 and lose it. But that's what happens with flexible spending accounts. The big difference is uh, you gotta use it or lose it. Whereas the HSA, it carries over, but you have maximum amounts that you can actually contribute. So those are some of the differences. And this actually breaks down that you can look at what's the difference between an health savings account versus a flexible spending account. Um, so this gives you the advantages and disadvantages that you can look through. All right, so I want to talk about commercial health insurance. Um, Most plans have commercial insurance, or this is basically anything that's not Medicaid or Medicare. These are your private insurance. These are some of the most common ones: Aetna, United Health, Humana, Blue Cross Blue Shield, Cigna. So remember, this makes up most of the percentage in the United States of how people pay for medication. Is usually paid through commercial or private insurance. Um, the employer contracts with the insurance company or companies to offer certain plans. So you get this one through your employer. While the workers are employed, the employer pays a portion of the monthly premium, and the remaining cost is deducted from the wage earner's pay prior to taxes. Commercial health insurance, again, this is the big one that's basically controversial right now. The Affordable Care Act, also known as the Obamacare. Um, It basically, so this was established in 2010. It sought to extend coverage to more Americans who are uninsured, without insurance, or underinsured, insufficiently covered. Um, Healthcare cost rises through higher hospital costs or taxes when individuals who cannot afford ongoing or preventive care are forced to go to emergency rooms. That's why I was saying that insurance companies rather you have a primary doctor to go through first, versus using the emergency room as your primary doctor. And as I stated before, there were a large percentage of people in the United States who didn't have insurance, didn't have a primary doctor, and basically used the emergency room anytime they got sick. And that actually adds to the cost, because the emergency room is really not set up the same way as your primary care physician. Your primary care physician can take better care of you, way better than an emergency room. Again, emergency rooms are for emergency situations, immediate situations where the patient needs immediate attention. They're not designed uh, to see people month after month, or whatever. Um, so again, healthcare costs rises through hospital costs or taxes when individuals who cannot afford ongoing or preventive care are forced to go to emergency rooms, fall into poverty because of medical costs and loss of work, or have a patient die from illness. Um, the ACA, which is the Affordable Care Act, mandated that all businesses with more than 50 full-time employees offer a health insurance option. So this was the first plan to basically state if a company or business employed more than 50 full-time employees, they had to offer some type of health insurance option that the patient can choose. So private insurance comes in three types. You got HMOs, health maintenance organizations. So they have their own staff of providers or a network of or preferred providers. Um, so HMOs basically have uh, their own providers. So if you're part of an HMO, the HMO will have their own distinct physicians, surgeons, you know, uh, pediatric doctors or whatever. They have their own organization of doctors that are covered under the HMO. You have something also called PPOs, preferred provider organizations. Um, so this one basically, if you're part of a PPO, they want you to use doctors who are contracted uh, with that particular PPO. Um, so with PPOs, you have they want you to use contracted providers. So if you fall under a PPO plan, and maybe there's a certain doctor that you want to see, um, that doctor may not be contracted under your health plan. So in that case, your insurance wouldn't cover that particular doctor, if that makes sense. So a PPO basically has certain doctors that they contract with, and others that they don't. The bad thing about the PPOs is they could be like a really great doctor that you heard about, and then you call that doctor's office to set up an appointment, and they tell you, oh, with your insurance plan, we're not contracted with your insurance plan, so you would have to pay cash. That's the downfall to having a PPO. The HMOs, the downfall for that one is basically they assign you doctors who are covered under their umbrella, which may not be a doctor that you want to use or not. So they basically are selecting the doctors for you with an HMO. Commercial health insurance for those who are business sponsored insurance who have lost or left their jobs. The employers are required to allow the former employees to stay on their employers' insurance plans at a premium cost for 18 to 36 months. This, I want you to be familiar with this. So this is an insurance called COBRA. It stands for Consolidated Omnibus Budget Reconciliation Act. So basically what it's saying is if you were let's say you had a job and you were employed full time for 4 or 5 years and you had insurance with that plan. Well, just say you left that plan for whatever reason and you're not currently working. You can go under the COBRA insurance, which basically what it really does is it requires your previous employer to keep you on an insurance plan at a full premium cost for up to 3 years. But if you do have COBRA, I just will say this, it's basically a transition insurance. So you just left one job where you had insurance. So you apply for COBRA, which allows your previous employer that you just left to basically keep you on a plan, but you're paying full premium cost for almost 3 years or whatever, potentially. That's the longest you can go. So it basically gives you coverage as you transition from one job to another job. But COBRA has very high rates. You're not going to get great rates under COBRA insurance. So as soon as you get a new job, you want to basically drop COBRA and get the new insurance. So it's basically a little transition insurance period. That's the best way to sum it up. And here is a little chart that basically sums up the difference between HMO and PPO. You got advantages and disadvantages on both sides. You just have to outweigh the two. For example, HMO is less expensive, but it has a much smaller network. PPOs is more expensive, but it has a larger network, a larger amount of doctors you can see. HMOs, you must use their network, so you have to use their doctors, which sometimes your favorite doctor or your preferred doctor is not in that network. PPOs, you can go off network, so you can see doctors who are not in that network. HMOs, you have less control of who you can see because, again, with HMOs, they basically are choosing the doctors for you. PPOs, you have more freedom to see the doctors that you want. You basically control the plan and control who you can see, more so than HMO. Your HMO, your network is local. Whereas your PPOs, you can move around. You can actually, if you live in Dallas and you want to see a world-renowned doctor that lives in Houston or Austin, you can actually move around and see that doctor with a PPO. So it depends on who you want. I mean, which one you prefer, because they have their advantages and disadvantages. And you can read these next slides to give you a little bit more in-depth information about the differences between HMOs and PPOs. And so I'm gonna end this part one here, and then I'll have one more part to close this out, starting with the supplemental health insurance, which I'll pick up in part two. Again, any questions? I know that sort of was a lot of material, but remember Fridays I will be available from 10 to 12:30, or you don't have to actually wait to Fridays. You can email me, and when this goes on YouTube, you can actually send comments on the YouTube, and I'll check them if you got comments about the lecture or whatever. So there's a lot of different ways you can actually ask me questions, email me, call me, respond when the video shows up on YouTube. And then Friday, I basically have a question and answer session from 10 o'clock to 12 o'clock. So we'll pick up on part two on starting with the supplemental health insurance on slide 46. Thank you.